So welcome to another session of podcast under the clinical snippets. So today's podcast will be a fantastic experience for all of you because this is not a simple podcast of any one single disease. In this podcast, this will be dealing with the topic, the broad topic that is dementias. So after mustering of a lot of courage, we had sent invites to all the global population of the elite dementias, starting from Mr. Alzheimer's to thyroid, and majority of those dementias have accepted our invitation and they will be coming to our podcast and we will be chit-chatting them and we will be engaging them with what they are actually, how they do their thing, how they can be prevented, yes or no, if at all fortunately or unfortunately is there any treatment for those dementias, and how you will be diagnosing them, and all these things one by one we will be entertaining with the dementias, and we will be enlightened by themselves, they will speak for themselves, and this podcast will go on the broader topic of dementia. So after this brief discussion of this podcast session, how it will go, let us invite the most super VIP, the very important dementia, rather I would say the boss of dementia, Mr. Alzheimer's disease.
क्या हुआ भैया, किधर जाना है? पॉडकास्ट डिमेंशिया पॉडकास्ट कहाँ पे है? हाँ मैं लेके जाऊँगा। यहाँ पे है? हाँ यहाँ पे। ठीक है। पॉडकास्ट हाँ पॉडकास्ट डिमेंशिया हाँ यही है। ओह हाँ।
So, because he was the super VIP guest of ours, I had called him early. Since 10 days he is in this campus, and since 10 days I have been personally accompanying him to show the path of this podcast where it is going to happen. Multiple times I have accompanied him and showed him the way how to reach the podcast, but unfortunately I just got a news there was some problem outside. Again, Mr. Alzheimer's was not able to find where the podcast is going on. We have to accept it because it is Alzheimer's disease. Yet, with due respect, I call the most important dementia first to our podcast, Alzheimer's. Welcome. Thank you, sir. Welcome. Thank you. There was some problem outside.
Well, I came here before, but then I was not able to recall.
Okay.
I did.
It's okay. I accept it. Now we are here in the podcast.
Have we met before?
Yes.
I just cannot recall it.
Hey, I am Dr. Acharya. Now you recall?
Have we?
N number of times we have met. This is the podcast you have.
Yes. A very genuine person.
Now you recognize.
Yes. Oh, yes.
Take your seat.
Thank you so much. Thank you so much.
So, Mr. Alzheimer's. First,
Yes.
salute to you.
Thank you.
In the global platform of dementic disorders, you are the reigning emperor. Obviously, you will be highlighting about yourself. The world knows about you, and you are the most common cause of dementia in the elderly. So
More than 65.
Yeah, in the elderly, and we will now chit chat with you. You have an ample opportunity to take your time and explain about yourself and how you create your havoc. So without wasting time, I will start you are ready?
Yes.
Can you introduce yourself from your own mouth for our audience?
Yes, for sure. A little introduction about myself. I'm a chronic disorder of the brain, which initially I affect the memory and the ability to think. and eventually I progress in a form that person is not able to do his daily routine activities. That is a very chronic form of mine.
So yeah, okay. If I just interrupt a little bit, the form of injury you cause to the brain, your basic pathology is maybe it's a neurodegenerative condition.
It's a neurodegenerative.
Yeah, it's
condition.
okay. Yes, a neurodegenerative condition.
Yes.
And you first affect the cognition followed by memory.
First, cognitive function is affected, and eventually leading to the memory.
So a chronic disease.
It's a very chronic disease. Yes.
So basically, what is the pathophysiology? What is the pathology? Molecular pathology? Is there any genetic significance? Are there any risk factors? How you choose your prey?
So basically, the pathophysiology of Alzheimer's is very chronic. Matlab, it is multiple factorial. Genes are also affected. Multiple chemical dysfunction is also affected in brain, as mentioned here.
Yeah, can you please?
Yeah, for sure.
Because I have done some little bit research.
Yes. Well, abnormal processing of the amyloid precursor protein, which is APP, eventually it leads to increase in formation, aggregation of amyloid beta, which also leads to inflammation. It is an oxidative damage. It decreases the clearance of amyloid beta peptide. It is excitotoxicity, pathological overstimulation of glutamatergic system.
So please let me interrupt. So you want to say that it is basically amyloid disorder? You have an amyloid disorder.
Yes.
To beta amyloid.
Beta amyloid. Yes.
And beta amyloid itself is causing inflammation and oxidative damage.
Oxidative damage.
Because it is an excitotoxic.
Excitotoxic. Yes.
And yes. And it is affecting the glutaminergic system.
Okay. It eventually leads to hyperphosphorylation of microtubules, which is stabilizing the tau protein and the formation of intercellular neurofibrillary triangles, which eventually leads to damage of neurons.
Oh, that means this glutaminergic system is also responsible for the beta amyloid related glutaminergic excitotoxicity.
Yes.
Hyperphosphorylation microtubules.
Yes.
Then the stabilization of this is most important, tau proteins. So tau protein and leads to intercellular NFTs. That is the basic pattern. That's death of neurons and
degeneration and damage of neurons.
Yes, sir. Kindly said, sir. Thank you. Fantastic elaboration of pathology. And is there any genetic variations?
Well, if there is dysfunction of any genes, like as mentioned here,
yes.
PSEN1 and 2 with ApoE mutation and TREM2.
So these are
the genes. If they are affected, chances of getting Alzheimer's
are more.
Is fourfold. It is more. Fourfold.
And the most important, we should always remember that it is all elderly suspect. More than
person who is more than 65 years of age, they are more prone to get Alzheimer's.
Sir, so what are the basic clinical presentations? How the dementia works and how?
Okay. As far as clinical features are concerned, there are stages, different stages. First of all, there is a preclinical phase, which actually lasts for decades, from 2 to 10 or more than 10. Well, in this stage, clinical features are not shown, appreciable. Well, in a laboratory it can be diagnosed, but clinical features are not there. Then comes the precognitive dysfunction phase. Well, there is cognitive dysfunction. The nature is very low, mild,
subtle nature.
But
there are clinically dysfunction starts.
Then comes the mild Alzheimer disease or mild Alzheimer dementia.
So here is the dementia.
Dementia, yes. This is the phase where a symptom can be appreciated. There is loss of memory, which is mild. Well, there is loss of memory. Person forgets things here and there. Then comes the moderate phase where the intensity of this clinical feature symptoms increases. The person is very easily confused. Person does not know where he kept the keys and all. And then comes the chronic phase,
like list of groceries
he forgets, and
keys and simple daily activity he forgets.
In chronic phase, there is loss to talk, loss to eat. He is not able to go to the washroom, and basically he requires the help of his family members and caretakers.
So caregivers
Is
tremendous
yes,
problem in
tremendous,
daily
and
functions.
life is chaotic in severe Alzheimer dementia.
So
Or
finally
this phase.
every part of memory is lost.
Every part of memory is lost.
So I think what you mentioned is the earlier phase of when the dementia starts, like forgetting keys and forgetting things, grocery list and all those things.
yes.
That means you are typically affecting the episodic memory part, like
Episodic memory,
which
yeah.
is
Yes.
responsible for the time and place and all
Yes.
those things.
For example, if I've kept my keys on my
Yeah,
table,
yes.
I
When
do not
did I keep
remember.
it? Where did I keep
Yes,
it? And
yes,
sometimes
yes.
like that. Okay.
At times I do not remember person's name. A friend calls me and I forget his name.
Lastly, pathfinding problems and
Pathfinding problem just happened.
Yes,
right now.
yeah. How do we diagnose you?
Okay, well, as far as diagnosis is concerned, first is the clinical form where the cognitive function is tested. The other part is the radiological form. The cognitive form, there are various scales which can be checked, like MMSE. According to the severity of my progression, my disease can be classified. It can be mild, moderate, severe.
Okay, basing on this scales.
On the basis of the scales.
So once scales are applied,
Yes.
the
The-
predisposition for clinical suspicion, elderly, forgetting, scales applied,
Yes.
and later on we can go for imaging.
Neuroimaging. This is
So what are these neuro? Can you elaborate, please?
well, there are different modalities which can be used, like MRI brain, like PET CT. Well, when MRI is done, there are various things which can be seen over this MRI. There is cortical atrophy. There is sulci gyra is the space is diminished. Well, these are the findings which you can see over MRI. The other scan which can be done is PET CT and tau related enhancement. Yes, protein
Tau
is
protein can be
tau
detected
protein
by-
can be detected by doing PET CT. Yes.
And please don't mind because I am your great fan. There are very specific regions in the brain where you start your journey, your neuroanatomic journey. If I am not wrong, just please excuse me. You can interrupt.
Yes.
Like you, I heard you start from the entorhinal cortex,
Entorhinal
the
cortex.
medial temporal lobe.
Yes.
Then you gradually progress from the medial temporal lobe to posterior
Posterior
temporal lobe,
temporal.
inferior temporal lobe. Then you go to the parietal
Yeah.
neocortex. Then ultimately the parietal lobe and the frontal lobe.
Frontal lobe is
And
affected.
associated hippocampus and all. So this is your journey.
Basically, this is my journey.
This is
Yes.
your
Yes.
anatomy journey. Okay. So how can we treat you?
Treatment. As far as my treatment is seen, there are things which can be done to prevent. Doing regular exercise, taking adequate sleep, eating habit should be good. Eating junk food is the thing which can it's a bad thing. Being socially active is some of the things which can be done to regress this disease or to minimize the
Maybe
chances.
learning a new language.
Learning
Maybe learning a musical guitar,
Yes.
new music and all.
Music
Yeah.
it can be done.
Okay.
Well, as in when this Alzheimer disease is affected to a person, the symptom can be controlled. We just control the symptom by taking pharmacological therapy. Well, as far as this pharmacological therapy is concerned, we have two category of drugs. These are cholinesterase inhibitor. A group of drug is there in this, and NMD antagonist drugs.
Here, this is your antagonizing.
Yes, NMD.
Excitotoxic.
Yes, yes.
Excitotoxic.
Yes. As far as acetylcholinesterase inhibitor drugs are concerned,
So we need more acetylcholine.
in the brain.
Yeah.
Yes, yes, yes.
Decreased acetylcholine is one of the neurotransmitters which is responsible.
Which yes, decrease in the
So we
level.
want more acetylcholine in
Yes,
the brain.
yes. Decreased level of acetylcholine can aggravate this disease.
So
Yes,
this is
exactly.
the play of neurotransmitters.
Neurotransmitter.
So acetylcholine esterase inhibitors.
Like donepezil, like rivastigmine, these are the drugs which can increase the level of acetylcholine in the brain.
Yes.
Another NMD receptor antagonist, these are mementamine. and recently these both the drugs are combined so that the function can be improved.
Both
And
drugs.
yes, improved, and the
Increasing the acetylcholine level at one hand,
Decrease,
and
yes.
Antagonizing the
NMD
NMD-mediated
antagonists.
excitotoxin.
Yes. With these pharmacological therapies, we can actually decrease the symptom of Alzheimer disease. Along with this, counseling and psychotherapy, it helps the person.
You are a big burden on the caretakers also, or prevention and all those things. Any final words?
If I am affected to the population, which definitely I am doing, especially to the person who is more than 65 year of age, the elderly population, the youngsters who are a chronic smoker, alcoholic, they are the ones who actually needs to think about it before taking this, that Alzheimer's can be affected in them.
Yeah. So there are risk factors.
Risk factors.
So
their families are affected.
youngsters.
Yes. Message to youngsters.
Young adults, that these are the predisposing factors.
Predisposing factors of getting
Because altogether we
Alzheimer's.
also know that chronic alcoholism will also cause dementia.
Dementia,
So you
yes.
have to be preventive. Exercise, like you highlighted, learning a new language, or
doing some productive thing instead of
yeah. So thank you very much.
Thank you
for
so
this light interaction. You have thrown light on every aspect of yourself. And unfortunate part is, yes, for this podcast is Alzheimer's disease is actually not treatable. It's not.
It is not
just
a-
a symptom, and it's not a completely treatable disease. So thank you again. Thank you very much for honoring us, joining this podcast. Thank you. The next guest is undoubtedly a very important etiological risk factor for dementia. In the category of principal etiologies that can cause dementia is multi-infarct dementia. Now I welcome multi-infarct dementia or vascular dementia, and we will talk to him.
Good morning, sir.
Welcome, vascular dementia. We already know that you are one of the most important etiologic factors.
Yes, sir.
When we classify dementias, your prevalence is great, and you come in the first headings of important causes of dementia. Can you again reintroduce yourself?
So basically, I'm vascular dementia. Any problems with the vessels during decreased blood supply to the brain causes decreased nutrition, leading to the decreased function of the particular lobe and causing dementia.
Yes. It can be a large vessel or a small vessel.
Yes,
Okay. To go further ahead, a little bit more light on this. What are the basic types you can present?
Sir, basically, I can present as large stroke or in multiple small strokes. Sir, we have classified ourselves as multi-infarct dementia, strategic dementia, in which there is a large stroke.
Yeah.
We have subcortical dementia, in which we have multiple small strokes in the lower part, termed as Binswanger's disease.
Yeah. Binswanger's.
Binswanger's disease, yes.
If I am not wrong, it is something like Binswanger's arteriosclerotic
Yes, sir.
subcortical encephalopathy.
Yes, sir.
Okay, that in the subcortex you act like this, multiple infarcts.
Yes, sir.
And maybe if I am not wrong, you are in this scenario, you are acting on the small vessels.
Yes, sir. Small vessels, particularly.
Okay, and that large vessel part is the major strokes what we talk of. Any other etiology?
So we have mixed dementia. I get mixed up with Alzheimer's, the most common etiology for dementia, and we both together play along.
Oh,
Then we have, sir, post-stroke dementia, in which after 3 to 6 months, I come into play after a stroke.
after a stroke.
Yes,
Okay.
sir.
And the most important thing is that again you can interplay with Alzheimer's.
Yes, sir.
Okay, aggravating the situation. Okay.
So, and the last type is hereditary vascular dementia with age it progresses.
Okay, there is a hereditary part to it also.
Yes, sir.
Inheritance part to it also.
Yes, sir.
What will be the basic clinical features when you attack?
Sir, when I attack with after a stroke, the patient can have personality changes. Like in frontal lobe, I'll present as personality change. If it comes to temporal lobe, the person can have memory loss or problems with recognizing objects. In temporal lobe,
Yeah. Here is the main temporal part and the dementia part.
yes, sir.
Mainly in the temporal lobe form, you present as memory loss,
And memory loss, language problems.
language problems,
Sir-
aphasias.
Yes, sir.
Yes.
In parietal lobe, the patient cannot recognize an object. He'll be unable to recognize anything like pen, paper.
Okay.
Sir, and then it comes to occipital. Sir, he'll have a visual problem.
visuospatial problem and
Yes,
visual
sir.
problems. And in frontal lobe, along with memory,
Personality changes, lack of interest, apathy.
abulia,
Yes,
and
sir.
all those things.
Sir, then we come to subcortical region, all the lower. Then he'll have a thinking problem. He won't be able to express or think new ideas.
Okay. So, in toto, the cumulative actions of all lobes taken into consideration, various forms and segments of memory, along with personality and behavioral changes and neurological abnormalities related to that specific lobe, we can identify.
Yes, sir.
And the basic etiology is obviously vascular, as you told us.
Where I reside, I play along.
Yes, fantastic. And diagnosis part?
The diagnosis is very simple. First, the history taking and the neuro examination. Neuropsychiatric examination mainly rules out where I am.
Yeah.
Then it comes to imaging part. So CT and MRI plays along to identify what caused the stroke.
Yes.
Then it second is last that we go for imaging and the diagnosis of the stroke area.
It's fairly easy.
Yes, sir.
And how do we treat you?
Sir, as such, I cannot be treated. After a stroke, it is only physiotherapy, rehabilitation, and the patients that you have to take with the patient.
Yes. Because it's permanent damage.
Yes, sir.
Permanent thing. So if I summarize, you told us about the basic etiology being atherosclerosis.
Yes, sir.
Sometimes, as we know that lipohyalurosis is another thing, especially lacunar and small vessel disorders.
Yes, sir.
And you can affect cortex and subcortical regions. Major strokes, when you come in, you play your role according to the dominant lobe, along with major focal neurological deficits that can be identified,
Yes.
like hemiparesis, and along with that frontal lobe changes, parietal lobe changes, and all those things. Minor strokes or recurrent strokes, like you told about subcortical
Yes.
arteriosclerotic encephalopathy of being Swanger's, where there is small vessel vasculitis, and there will be multiple areas of subcortical
Yes.
changes,
Small
that we can-
changes.
and we can detect them in MRI or CT. Okay.
So one of the
Is
most
there any characteristic feature between the imaging part where I can go for how to identify small vessel multi-infarct dementia, multi-infarct part? So yes, you have yes. While summarizing, when I talk about again the neuroimaging part, is there any specific neuroimaging features that will differentiate, especially the subcortical multi-infarct part from the major cortical infarcts and other infarcts part?
So the periventricular area enhancement will be seen in the MRI specifically.
Oh, specifically in the multi-infarct subcortical dementia part.
Yes.
Okay, periventricular enhancement. Okay, fantastic. And as you told, maybe we are going to just prevent things,
Yes.
like you told. Again, the lifestyle changes and all those things, diabetes, hypertension, risk factor assessment, and all those things, exercise, and no doubt about it. And is there any specific drug at least I can give to prevent as a treatment part of multi-infarct or atherosclerotic?
So
focal
if the infarct has taken place, then antiplatelet would be the drug of choices to
Yeah.
decrease
Yeah.
and then follow up with the physiotherapy for memory.
Yeah. Like we use dual antiplatelet therapy or
Yes.
single antiplatelet therapy, that is to be given.
So the most important thing about me is I am the second most common cause
Yeah.
of dementia
Yeah,
after
that is-
Alzheimer's,
yes,
and I
yes.
can play along also with that.
You are in the first category.
Yes, sir.
Thank you very much.
Thank you so much.
Thank you. Now we invite our next elite guest, that is frontotemporal dementia. Let us welcome him. Hello, sir.
Hi, how are you doing? How are you
yes,
doing?
yes, fantastic, sir.
Want
It's
some?
an honor. No, it's.
You
it's
can
okay.
have both if you want.
No, it's for you. It's for
I'll
you.
have it then.
Yeah, you have it. You are okay, sir?
Yes, I'm
First
fine,
of all,
thank you
it's
very
our
much.
honor. You accept our invitation to our podcast, Mr. Frontotemporal Dementia. Sir, be seated, sir. Yes. Okay, sir. You can here continue everything. There's no problem, sir. Yes.
Thank you.
Very good afternoon.
Good afternoon, good afternoon.
So, Mr. Frontotemporal Dementia. Yes. Quite a.
Yes, it's good.
Yeah. Quite a fantastic name. It's looking very catchy and neuroanatomic. So, sir, tell us something about you, sir.
I affect the frontal lobe, then temporal lobe, then comes the dementia part. So, I'm very extensive. I start slow, light, then extensively involve the brain and distort the personality of the patient.
Okay, you want to say that you affect the frontal lobe and temporal lobe, as the name suggests, obviously. Then you go for your dementia part. Okay, sir. A little bit more elaborate about it. So you will start with the. You do not start with dementia, I suppose.
No, no.
Oh, okay.
Dementia comes at the last.
It comes as the last. So can you elaborate on the real clinical features when the frontal lobe is involved, whether you simultaneously involve both frontal or temporal, how the clinical presentation varies?
Yes, I will tell you about it. Firstly, when I come, I start slow. Affect the frontal lobe, then distort the frontal lobe functions. Like he is unable to do his daily activities. Any goal-directed activity which previously he used to do, he is unable to do it. The executive function is lost. He is unable to do any activity like daily activities like buttoning of the shirt also. He will have to think twice, what should I do next? So the executive function is lost. Then be having some
Bizarre
behavior.
Yeah.
Like he will not be able to control his impulses. Like as you can see right there, I want to eat it both together.
Yeah.
And I can't control my impulses like this.
Yeah.
So the frontal lobe is getting affected because we have the prefrontal cortex that controls the inhibition. Social inhibition is lost. So I will not be able to control the symptoms. Then comes the temporal lobe functions. When the temporal lobe is involved, then it affects the language. So this type is called the primary progressive aphasia type. And then we have other two forms. Will I be elaborating the?
Okay, sir. Sir, is there any inheritance pattern or you can just attack anybody walking?
No.
Or is there any age preference or something like that? Anybody can be affected?
One second. I don't like this. It's kept like this. Wait like this.
Oh, you are obsessive about it. You seem to be obsessive about it.
I can't help. I have some OCDs, you can say. Now
OCDs, and for us maybe it is a perfectionist attitude, I don't know, but yes. And it's very fantastic of you that you have also acting and showing our audience how the patient is behaving. Okay, sir. My question was, what is the inheritance pattern? Is there any inheritance pattern or the epidemiologic profile? How you affect which age group?
Okay. I'll tell you about it. Firstly, I am the most common cause of dementia overall in age group of less than 60 years, and the third most common cause of dementia worldwide.
Okay.
I affect mostly families. Once I enter your family tree, I am not going anywhere because I am autosomal dominant, and I have two genes that are specific for frontotemporal dementia.
I have done some research. Is this correct?
Yeah.
Your inheritance is autosomal dominant pattern and MAPT
Yes,
gene
right.
and GRN gene.
These two genes are the main culprits. If they are present, then you are prone to develop frontotemporal dementia in the later stages. And I usually don't prefer females. My main preference is the young brains. Unlike my Alzheimer's friend who like to chomp on the old patients, I like young people.
So this is one of the most important feature of yours, that age less than in the younger population, if somebody develops dementia, we will more think of you, we will give respect more to you rather than Alzheimer's disease. And what about any molecular pathology in genes? How exactly in the brain, how the neurons and all, what are the pathological changes that happen in the neurons? Should I bring a new chair for you, sir?
No,
You are comfortable, sir?
The position is not
Okay.
Okay, I'll tell you about my pathophysiology. My main weapon is tau proteins. These tau proteins normally they form the microtubules and help in maintaining the neuronal structure. But when these tau proteins get hyperphosphorylated and they accumulate in the brain, thus these neurofibrillary tangles and the inclusion bodies, they mainly accumulate in the frontal lobe and the temporal lobe, and thus distorting the neuronal architecture, and the symptoms appear.
So key points are tau proteins. When they become hyperphosphorylated, then they form the neurofibrillary tangles and they distort the neurons and neurites, especially in the frontal and temporal lobe. and then you play on your things, clinical things. Okay, sir, interesting about it. You mentioned the word tau protein, sir. Are you the only condition who comes under this tauopathy, or you have your associates, cousins who can be conglomerated in this tauopathy, sir?
I have some cousins also. Alzheimer's is the most common cause of tauopathy overall. Then comes the progressive supranuclear palsy and the corticobulbar degeneration. Also, in Pick's disease, the tau proteins get accumulated, causing symptoms.
So Alzheimer's disease, you yourself, your highness, you yourself, then the corticobasal ganglia degeneration, and another thing, progressive supranuclear palsy. So you all come under the tauopathies. Okay. Sir, now will you please walk through the real temporal progression of your clinical presentation, temporal profile when the person is affected by you?
If you are so interested, I will tell you.
Obviously, sir, we are interested because we invited you because of this dementia podcast. We want to know about your dementic side and apart from your neuroanatomic pathologic side, sir. How is your temporal profile?
I start acting on the frontal lobe and distorting their functions. The main function is the executive function. He'll be unable to do his goal-directed activity.
Yes, yes.
Then he'll have a loss of social inhibition or impulse control.
Social disinhibition. Like these are the things, social disinhibition.
Oh, yes.
yes.
I can't control it.
Yeah, it's fascinating. Yes.
So, people might think he has gone crazy when a person is standing and laughing at his own wife's funeral. And eating
Paradoxical
chocolate, as you can
behavior.
see. He'll be having paradoxical behavior. He'll be eating the chocolate in front of everyone. And people might think that he has gone crazy or he has gone mad. But it's not him who's eating the chocolate. It's me. Chomping on is the frontal lobe.
Yeah. Well said, well said.
Then this type is called the behavioral variant. It's my first part. Then I have some other parts also when I affect the temporal lobe. The temporal lobe is affected, then the language is affected.
Yes.
So then I will be called as primary progressive aphasia. I have two parts. Primary progressive aphasia is divided into semantic type and the non-fluent type. In the semantic type, the patient will be gibbering and he will be speaking so much, but it will not make any sense.
What I have researched a little bit about this semantic aphasia, the semantic variant of here. There is inability to process words or understanding words, recognizing faces or recognizing objects. Am I correct, sir?
Yes.
This semantic memory part is usually dealing with these things.
Yes,
Am I correct,
semantic
sir?
memory is gone.
Yes.
It is called anomic aphasia. He'll want to say like this, it's a pen, but he'll say square root. It's anomic aphasia. And he'll not be able to recognize the similar faces.
Yes.
In the morning, he talk with his daughter. In the evening, he'll not recognize what the face is.
Yeah, face
It's called
recognition. Yeah.
prosopagnosia.
Yeah, prosopagnosia.
Prosopagnosia.
Yes, that is part. Okay.
Then I have the secondary part, who is non-fluent aphasia. In this, he'll not be able to make full sentences. If he want to say, I want to go to the shop to buy this, he'll only say to shop. He'll not be able to.
Maybe this is a frontal variant also, something related to Broca's aphasia type. Oh, okay. Oh, in temporal lobe also you can behave like this. Yes. Fantastic. It is getting really excited. I am getting really excited. Sir, then is there anything about how to diagnose?
Yes. Yes, you can diagnose me. I have three domains to diagnose me. First is the clinical domain.
Yeah.
In this, if a young male who was normal a day before, or he is developing slowly progressive abnormal behavior, the dementia part is not there, so the memory will be intact, but he'll act abnormally. The behavior will change. He will get very upset or very happy. He'll sit in a chair staring at the wall and not doing any goal-directed activity. His personality will change.
Yes.
He'll not be having impulse control. If you see any person shouting at a beggar, stealing from a beggar, or shoplifting bananas, you can suspect that there may be any pathology.
Yes.
Because it's not normal.
Clinical suspicion is first, like you have highlighted everything about. After once we suspect this is something odd, how we can go ahead, sir?
One second.
Yes.
Then the clinical suspicion is there.
Yes.
Then we see the MRI of the brain. we'll get an imaging done. The MRI brain will show frontal and temporal lobe involvement, atrophy and involvement. Then we can also use SPECT scan. In this, the hypoperfusion occurs in the frontal lobe and the temporal lobe. So we can suspect that it can be frontotemporal dementia. Then comes the genetic diagnosis. We can see for the genes, as you said, MAP, TNGRN gene can be seen, and the family should be evaluated for this.
Because there is a family history.
Family history.
Any treatment?
No. Researchers are trying many things, some interesting stuff, but there is no treatment for me as of now. There are some interesting theories they are giving up, like the tau protein which I was making.
Yes.
So they are making anti-tau antibodies so that they can destroy the tau that I so meticulously put in the frontal temporal.
Hyperphosphorylation is inhibited.
Inhibited. The hyperphosphorylation is inhibited and they are unable to get deposited. Then in the genetic variant, we can get the gene therapy done. The
Yes.
oligonucleotides can be implanted and this can help producing normal tau proteins. The abnormality can be protected. Then we have some medications like SSRIs for just like impulse control, and if OCD is there, then it can help.
Yes.
And behavioral therapy, I am a nightmare to the caregiver. The person itself is enjoying he's talking gibberish, he's enjoying himself. But the caregiver, it's a big job for him.
Yes.
These some can be helpful, but there is no proper treatment. Early diagnosis is a thing, family counseling is another, but there is no treatment for it.
Excellent, sir. Excellent for enlightening us about yourself. So, if I summarize, Your Highness, frontotemporal dementia, autosomal dominant you are, genetic inheritance like these genes are involved, you affect the younger population. Any person with dementia less than 60-65 years, you are the boss. Once suspected, the basic pathophysiology of yours is you talked about how you involve the frontal lobe, then temporal lobe, then dementia is the latter part. You talked about the tau protein abnormality, neurofibrillary tangle, hypophosphorylated tau, and accumulation of these abnormal tau proteins in frontal temporal lobe, depicting their own clinical nature of behavioral abnormalities, social disinhibition, uncontrolled behavior, and the temporal lobe aphasia part, the semantic variant of memory loss part, and all those things. Then obviously the diagnostic part is, I would say, after clinical suspicion, if I am correct, is that's a neuroimaging and the SPECT scan, hypoperfusion because of the atrophied frontal and temporal lobe. And ultimately treatment is, there is no holistic treatment or the evidence-based treatment. Yes, cognitive therapy and some research is going on about inhibiting the phosphorylation and those things. Thank you very much, sir. It's an honor to talk to you, and you have enlightened myself and my audience about yourself. Thank you very much. Enjoy your meal. Thank you.
You still don't want it?
No, it's okay.
Thank you.